Hello, everyone, and welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, and whenever curiosity calls. I'm Rojina, and today with me is my lovely little sister Nora.
Hello, everyone.
Today, we're investigating one of the most dramatic emergencies in gastroenterology, even more dramatic than our fights. It's upper GI bleeding.
So, a patient walks into the ER vomiting blood. Where is it coming from? How bad is it? And most importantly, how do we stop it?
By the end of this episode, you'll be able to answer all of these questions and be ready to handle any patient vomiting like a pro. So let's jump right into it. All right, Nora, let's start with the basics. What exactly counts as an upper GI bleeding versus, let's say, lower?
So, imagine a map of the GI tract. There is this anatomical landmark called as ligament of Treitz. It's basically where the duodenum meets the jejunum. Everything above that line is considered upper, while everything below is lower.
So, upper GI bleeding is any bleeding that originates proximal to, meaning before the ligament of Treitz.
Exactly. And to make it easier to remember which organs can be responsible, I like using the mnemonic every stomach doctor loves big paychecks. That reminds us that the bleeding could come from the esophagus, stomach, duodenum, liver, biliary system, or pancreas. This upper GI is everything that originated from the foregut during embryology.
So, basically, anything before the jejunum. Why do these organs bleed in the first place? Like, what are the triggers?
Well, it all depends on where the bleeding is. The most common category involves peptic disorders. These include duodenal ulcers, gastric ulcers, reflux esophagitis, and inflammatory damage such as gastritis or duodenitis caused by stress, alcohol, or even medications.
So basically, anything that makes acid erode or damage the protective lining of the stomach or the duodenum, one way or another, they can trigger bleeding.
Exactly. Another major category is portal hypertension. When pressure builds up in the portal circulation, it causes fragile blood vessels to dilate and rupture. This can be seen as esophageal varices, gastric varices, and portal hypertensive gastropathy. There is also a fascinating condition called as gastric intravascular ectasia, or GAVE, which is nicknamed watermelon stomach because of the striped red appearance of the stomach lining.
Watermelon stomach is honestly quite descriptive.
Right? Beyond those two major categories,
The peptic disorders and portal hypertension.
there are several additional causes we have to keep in mind. For example, bleeding in Mallory-Weiss tears is because of forceful vomiting causing mucosal tears in the esophagus. There may also be bleeding due to neoplastic causes like cancers of the esophagus, stomach, or duodenum. Then there are vascular lesions like Dieulafoy lesions, aortoduodenal fistula, and angiodysplasia. Other inflammatory or systemic causes include esophagitis, Crohn's disease, and hemobilia, which is bleeding from the biliary tree. And of course, medications like NSAIDs are infamous of damaging the gastric mucosa and causing bleeding. Occasionally, bleeding may even originate from pancreatic diseases or duodenal diverticulum.
That's a huge list. We could just think of anything that compromises the mucosal lining or the vasculature of the GI tract. But I'm guessing some causes are much more common than the others.
Definitely. The top cause by far is peptic ulcer disease, accounting for about half of the upper GI bleeding cases. Esophageal varices and vascular lesions are common but less frequent than ulcers.
Okay, time for a quick question to test our listeners and myself.
So, a 55-year-old man present with hematemesis. What is the most common cause of upper GI bleeding?
Okay, I'm gonna go for peptic ulcer disease.
And you are absolutely right. Peptic ulcers are responsible for about 50% of cases. You know, Regina, upper GI bleeding isn't just dramatic, it can also be deadly. Overall mortality sits around 5 to 10%.
That's already significant, but it gets worse if bleeding continues, I assume.
Exactly. If rebleeding occurs, mortality can increase dramatically, reaching about 40%. Outcomes depend heavily on age, how severe the bleeding is, and what other medical problems the patient has.
So, an elderly patient with multiple chronic diseases has a much worse prognosis than a younger, healthy patient, like me, for example.
Yeah, but there is some reassuring news. About 85% of upper GI bleeds stop spontaneously as the body forms clots naturally. Only around 5 to 10% of hospitalized patients ultimately require surgery.
Wow, actually, 5 to 10% is great. So, most of them stop on their own. But clearly, those severe cases are extremely high stakes. Okay, so let's zoom in our most common causes of upper GI bleeding, which is peptic ulcer diseases.
Bleeding ulcers are responsible for roughly half of upper GI bleeds. Interestingly, bleeding can be the first sign of peptic ulcer disease in about 5% of patients.
So sometimes you can't even prevent it by controlling the disease because it creeps up on you and suddenly bleeds.
Yeah, it's quite scary. Over a lifetime, about 20% of people with peptic ulcer disease experience at least one bleeding episode, and bleeding is considered the most lethal complication of ulcers.
So are there ways to predict which patients will do worse?
Some factors are associated with poor outcomes, like severe magnitude of initial hemorrhage in both rate and volume, as well as persistent hemorrhage, recurrent hemorrhage, advanced age, medical comorbidities, and coagulopathy.
There has to be some sort of a risk classification criteria or something.
Oh, there absolutely is. We have the BLEAD, risk classification criteria.
Cool, it says bleed, so that helps us remember that it has to do with bleeding.
Yeah, thankfully. But be careful. The criteria is spelled as BLEAD rather than a double E.
Oh, okay.
B stands for ongoing bleeding. L for low systolic blood pressure, especially if it drops below 80 millimeters mercury. E is for elevated prothrombin time. A is for altered mental status. And D stands for unstable underlying diseases.
So, if a patient has any of these factors, they are more likely to develop complications, rebleed, require surgery, and even die. Let's solve a practice question to solidify this concept. A 72-year-old woman presents with melena, confusion, hypotension, and her INR is 3.2. How many bleed risk factors does she have?
She has hypotension, elevated coagulation time, and altered mental status, which adds up to 3 risk factors. And remember, mortality increases with age, reaching up to 25 to 30% in patients over 80.
Even one risk factor significantly increases risk, let alone three. And the fact that she is an elder, are there any specific comorbid diseases that worsens the prognosis?
The worst ones are acute renal failure, respiratory failure, cirrhosis or chronic liver disease, and heart failure. These dramatically increase mortality risk.
All right, so all the big bosses are here: kidneys, lungs, liver, and heart. I've also heard that NG tubes findings can also be helpful in determining.
Yes, you can examine the color of the aspirate from the NG tube. Coffee ground material suggests older bleeding and carries a lower mortality risk, whereas bright red blood indicates active bleeding and a higher mortality risk. Other than NG tube finding, if a patient needs massive transfusions, that also suggests poor prognosis.
But the most important predictor of prognosis is endoscopic appearance, right?
Exactly. If the ulcer is bigger or just looks bad on endoscopy, like if you see it bleeding, then the rate of rebleeding increases. But if it's clean, happy looking ulcer, it would rarely bleed. And that's where the forest classification comes in. It categorizes ulcers based on their appearance during endoscopy. Forest 1 represents active bleeding and carries the highest risk. Forest 2A shows a visible vessel with high chance of rebleeding. Forest 2B shows an adherent clot with moderate rebleeding risk. Forest 2C shows a pigmented spot with lower risk. Forest 3 shows a clean ulcer base with minimal rebleeding risk.
So, as the ulcer looks more healed, the rebleeding risk decreases.
Exactly.
And the lower the stage of the forest classification, the higher the risk. Okay, let's say a visible vessel is seen in a duodenal ulcer, but it's not actively bleeding. What's the forest classification for it?
Since it's not actively bleeding, it's not stage 1. And since we see visible vessel, that means it corresponds to forest 2A and carries around a 40 to 80% rebleeding risk.
Which means aggressive treatment is required, obviously. All right, Nora, we've talked a lot about peptic ulcer, and now I want to shift gears to another huge cause of upper GI bleeding, which is portal hypertension. Where do we even start with that?
Honestly, portal hypertension bleeding is one of the most high risk and high mortality causes of upper GI bleeding. The biggest culprit here is bleeding from esophageal varices. In fact, variceal bleeding accounts for about 30 to 35% of deaths in patients with portal hypertension.
That is massive. So basically, if a cirrhotic patient bleeds, there's a huge chance varices are responsible.
Exactly. And here's a scary statistic. About 90% of cirrhotic patients will eventually develop esophageal varices. Out of those, around 30% will experience an upper GI bleed. And unfortunately, each bleeding episode carries a mortality rate of up to 25%. Even worse, about 70% of patients will rebleed.
Those are a lot of numbers, but what's clear to us is that it's a pretty significant issue for liver patients. That recurrence rate is terrifying. I want to try to understand esophageal varices better. So, what exactly are they?
Esophageal varices are dilated submucosal veins that form because of communication between the portal circulation and the systemic venous system. They usually occur in the distal esophagus. The esophagus is not the only organ that develops varices. You can see gastric varices as well, typically along the cardia and the upper greater curvature of the stomach.
And these varices vary in size, right?
Yes, they can range from very small veins measuring just 1 to 2 millimeters to massive veins reaching 1 to 2 centimeters. The larger the varices, the higher the bleeding risk.
So, when someone develops portal hypertension, blood tries to find an escape from all that high pressure within the portal system by running to these connections with the systemic circulation.
Exactly. That leads to formation of collateral vessels like varices.
So, we usually measure the hepatic venous pressure gradient, which is the difference between the portal vein pressure and the hepatic vein pressure. Is there a specific pressure gradient at which varices form?
Yes. Once the gradient exceeds 12 millimeter mercuries, varices can start forming and bleeding risk rises significantly.
We said that about 30% of varices will bleed. That means that not all varices bleed. How do we know which patients are most likely to bleed?
Three main factors increase risk of hemorrhage. First is the size of the varices.
So, bigger varices, bleeding more.
Yep. The second factor is the Child-Pugh classification, which reflects the severity of liver disease. And finally, the third is ongoing alcohol use, which worsens the liver injury and portal pressure.
I think that covers the upper GI bleeding associated with portal hypertension pretty well. Now let's talk about Mallory-Weiss tears. I think we're still hanging around near the esophagus with this one.
Mallory-Weiss tears typically occur after forceful retching or repeated vomiting. The lesion is basically a tear in the proximal gastric mucosa near the gastroesophageal junction.
So patients often present after heavy vomiting episodes.
Exactly. Common associations include alcoholism, hiatal hernia, NSAID use, portal hypertension, and even seizure disorders. It's more common in men and usually occurs in patients older than 60.
So what exactly causes a tear?
It's caused by inadequate relaxation of the lower esophageal sphincter during vomiting. This leads to stretching and tearing at the gastroesophageal junction. The tear is usually longitudinal, about 1 to 3 centimeters long, and involves the mucosa and submucosa.
So it's like the sphincter is so stiff that when there's so much pressure on it, it starts to tear.
Exactly.
Do these tears always bleed?
Only about 10% bleed significantly, but when they do bleed, it can be massive. Rarely complications like infections, inflammatory ulcers, or mediastinitis can occur.
So when do we exactly or how do we manage these patients?
Well, management starts with detailed history and physical examination. Since most bleeds stop spontaneously, supportive care is often enough. Initial management includes fluid resuscitation, correcting coagulation abnormalities, placing an NG tube, and monitoring fluid balance.
And if bleeding continues?
Then we add antiemetics to stop further vomiting, start PPI infusions, sometimes use vasopressin infusions, and transfuse blood if necessary, which is needed in about 40 to 70% of cases.
So can we go in with endoscopy or surgery to fix the tears or something?
Endoscopy can help us confirm the diagnosis and also provide some therapeutic interventions like coagulation or injection therapy, but surgery is rarely required.
Our next cause of GI bleeding sounds kind of strange. Dieulafoy lesion.
This one is fascinating. Dieulafoy lesion is a vascular malformation where a large submucosal artery protrudes through the stomach mucosa.
So it's just a big artery under the mucosa, but the mucosa itself is normal.
Yes, the overlying mucosa can appear completely normal without any ulcer. The bleeding happens when there's some erosion in the mucosa, and because the artery is so superficial, it may bleed.
So it's just an erosion and not a fully blown ulcer.
Yep. The artery is usually located along the lesser curvature of the stomach or in the gastric fundus.
And these patients just come to you vomiting blood?
Yeah, it's usually painless hematemesis or even melena. It usually occurs in middle age and more common in men, with 2 to 1 male predominance. Bleeding is usually massive because remember, it's an artery, but it may stop spontaneously. Unfortunately, diagnosis is difficult because there is no obvious ulcer and recurrent bleeding is common.
So how do you treat it? Do you just go in and cut off the artery?
Endoscopy is not very effective, so you need to go in surgically and perform wedge resection of the gastric wall.
Okay, Nora, our next cause of upper GI bleed is aortoduodenal fistula. Is that like a connection between the aorta and the duodenum?
This is one of the most catastrophic causes of GI bleeding. It occurs when an inflammatory tract forms between the aorta and the duodenum.
So what causes it?
There are two types. It's either primary, like what we see in infectious aortitis or aortic aneurysms, or it's secondary to placing a synthetic aortic graft, which is actually the more common cause.
So since it's the aorta, is it so scary? The bleeding must be massive.
Patients often present with something called Harald bleeding, which is a small warning bleed, but then suddenly they get a massive life-threatening hemorrhage.
That small warning bleed could be anything. How do you know that it's about to explode in your face?
You need to have a very high index of suspicion. So if you know your patient has an aneurysm or just had an aortic graft placed, you need to keep aortoduodenal fistulas at the back of your mind.
So what kind of imaging do you need to do?
Investigations include upper GI endoscopy, CT imaging, and emergency angiography.
This has to be a surgical emergency.
Definitely. You must perform an emergency laparotomy with control of the proximal aorta and removal of the infected or eroded graft, or fix whatever underlying cause there is.
Next up, we have angiodysplasia as a cause of upper GI bleed.
Angiodysplasia is an arteriovenous malformation.
That could also happen in lower GI.
Yeah, it can. For upper GI, it occurs specifically in the stomach or the duodenum.
Any comorbidities?
It's strongly associated with chronic renal failure and aortic stenosis.
So, what does it look like?
It appears as flat or slightly raised red lesions that are round and well circumscribed. On histopathology, they consist of dilated, thin-walled vessels.
So, we talked about a bunch of causes of bleeds in the esophagus, like varices and Mallory-Weiss tears, but are there any more?
Yes, but they are relatively rare and account for less than 3% of upper GI bleeds. Causes include infectious esophagitis, GERD-related erosions, Barrett's esophagus, medication-induced injury, radiation therapy damage, malignancy, and Crohn's disease.
So, what kind of infectious esophagitis?
Any kind of infection that can affect the esophagus in immunocompromised patients, such as those with HIV. The most common organisms include Candida albicans, herpes simplex virus, cytomegalovirus, and microbacteria. Bleeding tends to be slow and passive rather than massive.
So far, we've covered the stomach and the esophagus. What about the biliary system?
We have a condition called hemobilia, which is when anything causes bleeding into the biliary tree. The most common causes of hemobilia include trauma, procedures like ERCP or biliary surgery, tumors of the liver or the bile ducts, and fistula formation between the hepatic artery and the bile duct.
So, ERCP is not only notorious for causing pancreatitis, but it can also cause hemobilia?
Yes, when you insert an endoscope into the ampulla and inject contrast into the biliary system during ERCP, so much can happen, like pancreatitis and hemobilia, as you said, but also cholangitis and bile duct injury.
Oh my God. So, we've covered so much during this episode, but we've finally reached our last etiology of upper GI bleeds, which is duodenal diverticulum.
So the duodenum is actually the second most common location for diverticula in the GI tract after the colon. Most of the time, duodenal diverticula are asymptomatic, and they are more common in females.
So, where exactly in the duodenum do we find them?
Most of them are near the ampulla of Vater, while only a few are going to occur in the third part of the duodenum.
So, would we find only one or multiple?
Usually just one.
So, how do patients present since it's so close to the ampulla of Vater? Do they have biliary symptoms?
Symptoms are often vague, such as nonspecific epigastric pain. However, complications may include bleeding, obstruction, perforation, pancreatitis, cholangitis, and recurrent bile duct stones that may still be there after gallbladder removal.
So, if you have a patient with gallstones and you remove their gallbladder, but they still keep getting stones, you should suspect a duodenal diverticulum.
Exactly.
Do we need to remove the diverticulum surgically?
Most cases are only managed conservatively. We usually leave them alone unless complications develop.
Okay, Nora, we've got a problem. If you're an ER and a patient walks in vomiting blood or telling you they have a black teary stool, it could be literally anything. There are so many possible causes, but we have to act fast and stabilize the patient, even if we don't know what is actually bleeding, because it could be a very urgent scenario.
Exactly. That's why we have a structured approach. We have 4 goals during management that we can remember with the mnemonic ARID: assessment, resuscitation, identifying the source, and definitive therapy.
So let's start with the assessment.
Assessment involves a detailed history and physical examination. We ask about the type of bleeding, associated symptoms, medication use, and previous GI disease. On examination, we look for shock, signs of liver disease, and confirm melena through the rectal exam. Labs such as CBC, coagulation studies, liver function tests, pancreatic enzymes, renal function tests, and blood typing are essential.
So we assess the patient in order to form some differentials that will guide our management. The next goal is resuscitation or rescuation, and this one is life-saving.
Yes, resuscitation is very important in acute settings. We establish 2 large IV lines, administer fluids like normal saline or lactated ringers, transfuse blood if necessary, correct coagulopathy, monitor urine output to look out for dehydration, and consider ICU admission. We can place an NG tube to help clear the stomach. We may even have to protect the airway with intubation.
So, after stabilizing, we need to identify the source of bleeding to be able to stop it.
Correct. Emergency endoscopy is the key diagnostic and therapeutic tool, but only after you stabilized your patient and prepared them for endoscopy by gastric lavage and airway protection. If you don't find anything on the upper endoscopy in a patient with upper GI bleed, that is a very bad sign because it could mean a brisk lower GI bleed that is so severe, making blood travel all the way up.
Wow, all right. So, we've got our differentials, we've stabilized our patient, and hopefully identified the source of bleeding. We need definitive therapy now.
Medical therapy involves intravenous proton pump inhibitors and stopping NSAIDs if the patient is taking them. Some endoscopic therapies we can do include cauterization, injection therapy, clipping, or banding, which significantly reduce mortality. However, if all of this fails, surgical intervention becomes necessary.
Okay, so what kind of surgical therapy are we talking about?
Surgical treatment depends on ulcer location. Duodenal ulcers are treated with ligation of the bleeding vessel, ligation of the gastroduodenal artery, and truncal vagotomy to reduce acid production.
And gastric ulcers?
Bleeding gastric ulcers often require surgical resection because of the high risk of malignancy and high rebleeding risk. Endoscopic localization is essential before surgery.
Do we do anything specific for esophageal varices? I've heard about using beta blockers as prevention.
I'm glad you brought this up. The main thing we do for primary prevention of bleeding in the esophageal varices is giving non-selective beta blockers, especially propranolol.
So, how do beta blockers help?
They decrease splanchnic blood flow, which reduce portal venous pressure. By lowering portal pressure, they decrease stress on varices and reduce the risk of rupture.
So, how effective are they?
They can reduce the risk of hemorrhage to about 25%, which is a huge benefit for cirrhotic patients.
Okay, that was for prevention, but what do we do if a cirrhotic patient arrives actively vomiting blood from varices? What's our step-by-step management?
There is a great mnemonic to remember the management sequence which connects with the disease very nicely. The mnemonic is the word variceal.
Can you walk us through it?
First is the volume resuscitation. Those patients are often in hemorrhagic shock, so we immediately give IV fluids and blood transfusion. Second is assess with EGD, meaning emergency endoscopy. This helps confirm the diagnosis and allows therapeutic intervention.
So far, it's the same as what we do for any upper GI bleed. So VA now R.
Third is REACH for Blakemore tube if needed. This is a balloon tamponade device used to compress bleeding varices temporarily. Fourth is infused vasopressin. This medication reduces portal blood flow and helps control bleeding. Fifth is coagulation normalized. We correct clotting abnormalities using plasma or platelets. Sixth is encephalopathy treatment. Since liver patients are at high risk for hepatic encephalopathy and upper GI bleed increases the risk. Seventh is angiogram to perform TIPS procedure if bleeding persists. And finally, last resort is surgery if all other methods fail.
Okay, that's a very heavy mnemonic. So we go with volume resuscitation, then endoscopy, then Blakemore tube, then we give vasopressin, then we normalize the coagulation status, then we treat the encephalopathy, then we go with angiogram, and finally our last resort is surgery. How does vasopressin help?
Vasopressin works by constricting blood vessels in the splanchnic circulation. This reduces portal blood flow and lowers portal pressure. It also constricts esophageal smooth muscle, which helps compress bleeding varices.
So, is there any risk to using it?
It can reduce blood flow to the heart, so it's contraindicated in patients with cardiac ischemia or coronary artery disease.
Okay, so what about somatostatins? I know it's also used.
Somatostatin causes vasoconstriction of this plaque circulation, similar to vasopressin, but without the dangerous cardiac side effects.
So it's safer.
Exactly. That's why somatostatin and its analog, octreotide, are commonly used today as first-line pharmacological therapy for active variceal bleeding.
So we use non-selective beta blockers for prevention of variceal bleeding, and then we use somatostatin analog or octreotide to treat active bleeding.
Exactly.
We said something about Blakemore tube earlier. What's that?
It's like a balloon tamponade. A Blakemore tube is inserted into the esophagus and the stomach. The balloon is inflated to apply direct pressure on bleeding varices.
So it physically compresses the bleeding vessels.
Exactly. But it's only a temporary measure because it carries serious complications like esophageal rupture, tissue necrosis, aspiration, and airway obstruction.
So it's basically a bridge until definitive therapy.
Yes.
Can you use endoscopy for variceal bleeding as well?
There are two main types, endoscopic sclerotherapy and endoscopic ligation.
How about you explain the sclerotherapy first?
Sclerotherapy is when we close off the vessel by injecting a chemical irritant that causes thrombosis and fibrosis.
And endoscopic ligation, the second method is?
Endoscopic band ligation involves placing rubber band around the varices to cut off blood supply and make the varices collapse.
So which one is better?
Band ligation is safer, provides better bleeding control, and causes fewer complications than sclerotherapy.
Okay, so we previously mentioned angiograms, and you said something about a TIPS procedure?
TIPS stands for transjugular intrahepatic portosystemic shunt.
So how does that work?
TIPS creates artificial channel between the portal vein and the hepatic vein. It allows blood to bypass the liver and reduce portal pressure.
So it relieves the pressure that caused the varices in the first place.
Exactly. TIPS can remain functional for about 6 months to 2 years. Mortality from the procedure is about 10%, but it's life-saving in refractory bleeding.
All right, Nora, my sister, this was a very heavy episode. Before we sign off, let's recap this whole upper GI bleeding roller coaster from start to finish.
Let's do it. First, we defined upper GI bleeding as anything proximal to the ligament of Treitz. So bleeding from esophagus, stomach, duodenum, liver, biliary system, or pancreas.
Then we broke down the big categories of causes: peptic disorders with mucosal damage from acid and inflammation, as well as portal hypertension with pressure-driven bleeding from dilated veins.
Exactly. And we emphasize that peptic ulcer disease is the most common cause, around 50% of upper GI bleeds, while varices and vascular lesions are major players too, especially in cirrhotic patients.
And we didn't forget the extra suspects: Mallory-Weiss tears after forceful vomiting, as well as some cancers, vascular lesions like Dieulafoy and angiodysplasia, rare but catastrophic aortoduodenal fistula, infectious esophagitis in immunocompromised patients, hemobilia from biliary bleeding, and finally NSAIDs, pancreatic sources, and even duodenal diverticulum.
Then we talked about why upper GI bleeding is such a big deal. Mortality is about 5 to 10%, but if the patient rebleeds, mortality can jump around 40%, especially in older patients and those with major comorbidities.
But we also gave the good news: around 85% of upper GI bleeds stop spontaneously. So most patients stabilize with proper early management and only a minority need surgery.
After that, we zoomed in on bleeding peptic ulcers and how to risk stratify them using the BLEAD criteria: ongoing bleeding, low systolic blood pressure, elevated PT, altered mental status, and unstable disease. Plus, we highlighted the worst comorbidities: renal failure, respiratory failure, cirrhosis, and heart failure.
And we added extra prognostic clues like NG tube aspirate color, transfusion requirements, and most importantly, the endoscopic appearance.
Which leads to the forest classification. Forest 1, active bleeding is highest risk. Forest 2A, visible vessel has major rebleeding risk. Forest 2B is adherent clot. Forest 2C is a pigmented spot. And Forest 3 is a clean base with minimal rebleeding risk.
Then we went through portal hypertension, bleeding, and varices. How varices form through portal systemic collateral pathways. Bleeding risk rises when hepatic venous pressure gradient exceeds 12 mm mercury, and bleeding risk increases with large varices, higher child PU class, and ongoing alcohol use.
And we covered key prevention and treatment. Primary prevention with non-selective beta blockers like propranolol to reduce portal pressure and lower the chance of hemorrhage.
Then for active variceal bleeding, we used the variceal mnemonic. Volume resuscitation, assess with endoscopy, reach for a Blakemore tube if needed, infuse vasopressin, normalize coagulation, treat encephalopathy, angiogram for TIPS, and last resort is surgery.
Plus, we compared drugs. Vasopressin decreases portal flow but can cause cardiac ischemia, while somatostatin and octreotide reduce portal pressure with fewer cardiac risk and are commonly used first line.
We also hit the procedural tools. Blakemore tube is a temporary bridge with serious risks. We also compared endoscopic sclerotherapy and band ligation, and we emphasized that band ligation is safer with better bleeding control.
And when everything fails, we go advanced. TIPS creates portosystemic channel between the portal vein and the hepatic vein to drop portal pressure and control refractory bleeding.
Finally, we wrapped it all together with the universal management approach. ARID, assess, resuscitate, identify the source with endoscopy, and give definitive therapy using PPI. Endoscopic options or surgery depending on the cause and severity.
So if you remember nothing else, upper GI bleeding can look dramatic, but your approach should be systematic. Stabilize first, then diagnose, then treat. And always think about peptic ulcers and varices as the top two big buckets.
Exactly. So assess, resuscitate, identify, and treat. Endoscopy first, surgery if necessary, and for cirrhotic patients, think prevention early with beta blockers, and act fast when varices bleed with somatostatin. Okay, thank you all for joining us on this bloody episode of PodBites. Until next time, inshallah.
Yep. Yep. There might also be bleeding due to neoplastic causes like cancers or أمزح. ليش أنا كذا قاعد أشوف أشياء مكتوبة؟
زوم إن.
وين مسوية زوم إن؟
يا صار علي. والله فعلا البود بايتس ما هو دراماتيك أكثر من الأور توكس. That was a lie.
About 85% of upper GI bleeds spontaneous. ما أدري. يا ويلي.
اشربي موية اشربي موية.
إي والله.
Oh, is or the only one.
خلينا نسجل.
في.
رويدي يلا.
استنوني انتم. يلا طيب.
L for low. لا إله إلا الله. The worst ones are acute renal failure. But then suddenly they get a massive life-threatening hemorrhage. لا. If you don't need it.
If you don't need.
Sixth is insympathetic.
So that's a very heavy mnemonic. So we go with volume resuscitation. Right.